So the surgery could be 100% successful, and you feel great. And then 6 months later, you can barely walk because all that scar tissue has built up.
And even think of that back to obviously that push on the nerves.
Right, exactly. Now, if it's the knee, if you have to have a knee replacement and you have keloid scarring, it's not such a big deal, and I say that, but they can go in. If you develop scar tissue, they can go in and manipulate that knee so that they can take that scar tissue out. But every time you open up a person that had it, whether it's the neck or the back, they run the risk of paralysis. So we don't want to do that. So I don't know of any surgeon that would touch, unless it was a life or death situation, they're not going to do surgery. Because the potential is that if that patient develops that scar tissue, they're going to be worse than before they went in.
Is there a time frame on when you can give the steroids for the keloids? Like, can you have it for years and then be injected with it?
No, yes, you can have it for years and it can still work, absolutely, yeah. But did you notice when I said that usually it involves an injury or surgery, right? I had a student one time, she had keloid scars all over her body. And she would wake up with them. No injury, nothing. She would wake up and she'd have one on her face. She'd have some on her back, on her arms. And she told me that she had been to all different dermatologists and no one could figure out what was going on. So she went to a dermatologist in New York who still couldn't figure it out, but he thought that it had something to do with lymphoma, with the immune system. So he put her on chemo and it worked. And the ones that were existing, they went away. It was amazing. But when she came back here to go to school, she lost her insurance and she couldn't continue with the chemo, and they came back. But it was just, she'd come in one day and she'd have this keloid on her face. I'm like, what happened? She's like, I don't know. I just wake up and they're there. So very strange case.
I have one more question. Sorry, it might be, and I don't know, my brain's not working through it enough, but, so if they go in and say they remove some of it, when it scars back up, will it be another keloid?
This? No.
They go
No,
in and.
usually the steroid injections are pretty successful. They can grow back just like anything else, and everybody responds differently. But usually with something like this, for sure the redness will stay, should be permanent, it won't come back, and it should be flatter.
Yeah.
So,
Is that,
but you always have cases where, it's gonna defy that, and they'll come back. Even with the knees, when they go in and they take away all that scar tissue, they may have to go back and do it again. So, yeah. That's why what we're doing now is, let's say someone had a knee injury and they didn't have surgery, but they injured their knee and it left scar tissue. And then let's, fast forward 10 years and they the doctor says you have to have a knee replacement. Well, what they should do is make that patient do physical therapy first to try to loosen up that scar tissue as much as possible before the surgery. And then the prognosis is better. Okay, so what types of tissue have the greatest capacity to regenerate? That would be epithelial and connective. What type of tissue have the limited capacity to regenerate? That would be muscle and nerve tissue. So you want to know that. And here is what I said earlier, the healing of a minor wound. So here's our connective tissue. We have our cut, obviously we're going to have blood. And these fibroblasts, or fibrin, is going to come in and it's going to fill that cut from the inside out. You see how it's working there? And then of course, if someone has hemophilia, this doesn't take place, so they just keep bleeding and bleeding and bleeding, which will usually lead to a blood transfusion. And here we have new connective tissue replacing the epithelium and forming a scar. Okay. This is normal. This is what, and look how nice the epithelium has healed on top.
Dr. Penny, can you go to the previous slide just real quick? I'm sorry.
Sure.
That's great.
Okay. Whoops. All right. Let's talk about body membranes. Body membranes. There's some terms that I absolutely want you to know, and I want you to remember. You can't dump it, okay? So, body membranes cover and protect the body surface, line body cavities or cover internal organs, cover the inner surfaces of hollow organs, anchor organs to each other or to bones, and they can secrete lubricating fluids. When you think of our organs, you want to think like our lungs, for instance. They secrete a lubricating fluid so that it reduces the friction. Okay. Two major types, epithelial membranes and connective tissue membranes. So this is a lot of verbiage on 14. Basically, I want you to know this right here.
We're all still doing the last of this.
Oh, I'm sorry. Marina. Okay. So what is the purpose of membrane secretion of lubricating fluids? In certain areas of the body, membranes secrete lubricating fluids to reduce friction during organ movement. And again, one that's really prevalent is going to be in the lungs. Because what happens every time we inhale, what happens to our lungs? Yeah, then we exhale. So we have to have that fluid. Just think about, you know, not too long ago, if a baby only weighed a pound, they never survived. And it wasn't because of their heart not being developed enough. It actually had to do with their lungs. And there's a fluid, it's called surfactant. And that surfactant wasn't, how do I say, developed or available when the babies were born premature. And so they died of respiratory issues. But it was usually never the heart. Yeah, because the surfactant will reduce the friction. Now today, babies that weigh a pound, they actually can survive.
Is there something they're using as that
Yeah,
surfactant?
it's like an artificial surfactant.
That's cool.
But
And
it is
do they
amazing, isn't it?
Like, I wonder how they get it in there.
Yeah.
My friend just had her baby and he's 2 pounds.
Yeah.
And he's in the NICU, but he's doing well.
Yeah, he's gonna, yeah. It's amazing that they can do that now. It wasn't that long ago they couldn't. Okay, slide 15. You're going to want to spend some time on this slide studying the picture, okay? So if we start out at the top, the mucous I got a new pointer and I have no idea what I'm doing.
It's always finding the new buttons.
I know, right? Okay, whatever. The mucous membranes. This is going to be important for you as nurses because if you have someone, let's say you have a patient that comes in and they've had gastroenteritis for 3 or 4 days. They've been vomiting, they have diarrhea. What do you think these mucous membranes are going to be like? Do you think they're gonna be wet and moist, or are they gonna be dry? They're gonna be dry because they're gonna be really dehydrated. So, mucous membranes. Cutaneous membranes, cutaneous is skin, which is what we're going to be talking about next week, skin. Visceral pleura. This is something I really want you to know. Visceral pleura. We're gonna break down the name. So, I want you to know that visceral means organ. Okay, anytime you see the word visceral, I want you to think of organs. So, visceral tells you that we're talking about an organ. Pleura tells you that we're talking about the lungs, right? Because pleura means lungs. So visceral pleura is actually going to line the lung. Do you see that? It's the light blue, and it actually touches the lung. It's going to line the lungs. Now, let's look at the next one, parietal pleura. Well, if we just look at pleura, you know it has something to do with the lungs, right? But it's not visceral, it's parietal. So for parietal, I want you to think of outside the organ. So it's going to be, it's still focused on the lungs because it says pleura, but it's the outer part of the lung surface. Okay, it's on the outside. And that's the purple one, that's the dark purple.
So mine's the outside of the lung?
Yes, or the, I just don't want you to confuse it with visceral pleura. Visceral pleura is actually touching the lung.
So
And parietal pleura is actually going to line the cavity, I think is a better example. The parietal pleura lines the cavity.
Would it be fair to say that visceral membranes are an inner organ membrane and parotial membranes are an outer organ membrane?
Yes, that is exactly, because it's going to line that membrane or that cavity. And then we have the diaphragm. And I'm gonna give you some information here because I want you to remember it. The diaphragm is actually innervated by a nerve called the phrenic nerve. P-H-R-E-N-I-C, phrenic nerve. And the reason I'm telling you this is because the phrenic nerve originates way up here in the neck. So if you have a patient, let's say they're in a car accident and they break their neck, and that phrenic nerve is compromised, well, how are they going to present if that phrenic nerve innervates the diaphragm?
Yeah.
Yeah, short of breath, right? They're not going to be able to breathe or have very difficulty in breathing.
So the diaphragm is connected to the phrenic nerve? Is that
Yes, and the phrenic nerve originates way up in the neck. And we'll talk more about that as we move forward. But I thought if I mention it now, it'll stay with you and because I'll be bringing it up later. Okay, now we have another term, the visceral peritoneum. Well, visceral tells you that it's lining the organ. Peritoneum tells you that it's the abdominal region area, and in this case, obviously, it's going to be the stomach. It's going to be the stomach. So the blue is lining the stomach, so visceral peritoneum.
What, sorry?
Which one? Peritoneum is actually telling you that it's the abdominopelvic cavity. It's the abdominal, it's all of this area. But visceral narrows it down for you, so it's just gonna be the stomach. Now, if we look at the next one, parietal peritoneum, you see this dark purple line? That's the parietal peritoneum, and it lines the entire abdominal pelvic cavity. Are we okay with those? Because I will have questions, because I really want you to know these. Are we good? Yeah. All right. Excellent. So type of body membranes. So we have cutaneous, which is skin. We're gonna spend quite a bit of time talking about skin. I think it's, from now on, it's gonna be much more exciting, okay? Because we're gonna talk about everything that is going to pertain to you as nurses, right? We're gonna talk about burns, we're gonna talk about bed sores, we're gonna talk about skin cancer, so. All right. And let's see, what else? Don't have anything on that yet, I'm gonna wait. The skin covers body surfaces exposed to the external environment. The primary organ of the integumentary system, of course, is our skin. The skin is actually the largest organ in the body. It accounts for 16% of the body weight. You wouldn't believe, but skin is actually pretty heavy. Epithelial tissue membrane contains many sweat and oil glands. We'll talk about all those. So serous membranes, composed of 2 layers. We have an epithelial sheet, a connective sheet. The only thing I want you to know here is that the pleura surrounds each lung and lines the thoracic cavity. Thoracic meaning chest. Peritoneum covers abdominal visceral and lines the abdominal cavity. So if it's lining the abdominal cavity, what do we call it? Not visceral, but
If it's lining what, I'm sorry.
if it's lining the abdominal cavity, remember the dark purple?
Peritoneum.
Peritoneum,
Peritoneum.
parietal peritoneum. And if it covers the stomach, it's visceral peritoneum. And pericardium surrounds the heart. I don't have anything there. Nothing there. Neoplasm on slide 22, I want you to know is any abnormal cell growth. Growths can be benign or malignant. So I want you to think, if someone has a neoplasm, they're usually benign. But they can be malignant, but they're usually benign. Don't have to worry about 23 at all. I'm gonna talk about these later. Factors that may lead to cancer. I do want you to know these, genetic factors, carcinogens, sometimes called mutagens. Age is a factor, which I don't like because I think we miss a lot.
Age is a factor in like every pathology there.
Yeah. You're gonna learn, like in medicine, unfortunately, it's all about math.
And the youth is based
So-
on the young.
Well, what it is, if let's say you have a patient that comes in the winter, and they have a cough. I guarantee you, no one will even check their lungs. They're just going to say that they have bronchitis, and they'll give them a prescription for it, you know. But, it could be that that patient has lung cancer, right?
What is it, if you have a chronic cough like over 4 weeks, they'll finally take you serious and
Oh,
check
they don't
something?
even, I guarantee that when you go in, because 85% of the time, they're gonna be right by
It is.
saying.
It's bronchitis.
But even
that it's
here, like
bronchitis.
my daughter, when she got diagnosed with cancer, it took them almost 8-9 months because the only difference that was happening with her was she was getting more seizures. So then they just kept increasing her medication instead of doing any scans or anything. So finally, in the ER doctor's like, why haven't they done any scans? Like, you've been here almost every day for the last 9 months. So then they finally did an MRI and that's how they found it.
Yeah.
And by that
It's-
time, she had gotten about 26 additional tumors from what she should have
Which
had only once.
shouldn't have had, right, that's exactly right. I don't, yeah, so I don't like this so much, because they look at someone and they say, well, they're 25 years old, and they've had stomach issues. Well, it's no way it's stomach cancer, right, because they're not old enough to have stomach cancer. So, we don't go any further with it. But, you know, that, because 85% of the time, we would be right by saying that. Metabolic factors like diabetes, things like that. So people with metabolic disorders such as diabetes and obesity are often at a greater risk for developing cancer. A metabolic disorder can happen when abnormal chemical reactions in the body alter the normal metabolic process. Cancer detection and treatment. So self-examination is very important, not just for breasts, but also for men for testicular cancer. Testicular cancer is actually higher in this country than it has ever been, and it's deadly. You know, it's not like prostate cancer where it's slow growing. Testicular cancer is very aggressive. So it's very important that men do self-exams just like women with breasts. Medical imaging, blood tests, biopsies, chemotherapy, radiation, laser therapy. They're starting to do immunotherapy now, which is really cool. The patient is less sick during the treatments, and they're getting pretty good results.
I got to see the Y90 treatment for liver cancer
Oh,
first
did
again
you?
about 2 years ago. It's definitely different.
It's pretty amazing. My aunt had stage 4 lung cancer, and it had spread to her clavicle, so it was in her bone. And she was doing immunotherapy, and she lived for about 3.5 years, which is amazing with a prognosis like that. So.
I have a question.
Uh-huh.
So I know, like, say if breast cancer runs in your family, you know, you could do the BRCA test to see if you have the gene, things like that. But factors to like qualify to take the BRCA is like you have a sibling, a mother, an aunt that had breast cancer. Is that like what if you have a brother that has prostate or testicular cancer? Is that a
Like a marker?
yeah,
like a
sort of
thing,
like
yeah.
for a sibling?
Yeah, they
Would
will
it be-
still, yeah,
Okay.
and they will be more likely to listen. You know, I always tell people, you know, if you feel a lump on your breast, you know, I would do everything, you know, just lie and say, hey, you know.
That's exactly what I was gonna say.
No, I know that sounds horrible,
It doesn't.
but you just don't get the,
The help you need.
no.
Push
And
it.
they do go by age, and they're like, oh, there's no way you have breast cancer, you're only 20. Well, let's see. And then this you can read, and I'm not gonna test you on these, it was for your information about chemotherapy and how they're using laser therapy now that destroys tumors, which is really cool. And they use it with chemo and radiation, but they're getting pretty good results, so.
Is that more for, just the tumor, or is that also for pain, or is it still just radiation?
Oh, it's for pain too, though, yeah, they use it for pain as well, yeah.
Red light therapy.
Yeah. It's nice because it's non-invasive.
It is.
And, let's say you're just doing it for pain, because radiation is very painful. Chemo can be painful, it causes lots of issues. If nothing else, the laser could help with the pain,
That's the,
which is
so
fabulous.
my daughter, her cancer's in her retina of her eyes, so one of her eyes was really